I would like to commend the Brain Foundation and Pramila for bringing together such like-minded scientists with the objective of trying to find a treatment for autism as well as understand autism better. My presentation today will be discussing potential for prevention of developmental disorders, including autism. The presentation will be partly theoretical, partly data-driven, with the objective of trying to prevent the development of autism. Developmental disorders start in the womb and are influenced by maternal and paternal genetic and epigenetic makeup. They are also affected by imprinting genes, maternal nutritional status during fetal development, neonatal nutritional status during childhood, and potential various environmental factors. As we understand autism spectrum disorder today, we know that it is a heritable multi-gene disorder. It is heritable but not inherited, since it is not a single gene defect. It does not follow Mendelian genetics. And so far, the various defects described are gene copy number variations, deletions, duplications, inversions, gene-gene interactions, gene-environment interaction, as well as epigenetic effects. Therefore, maternal nutrition status that can influence gene expression, gene-gene interaction, epigenetic regulation, and cellular proliferation can have a profound effect on the structural development and functional refinement of the brain. This Pandora's box holds the secret and is greatly influenced by maternal metabolism. It is the maternal metabolism that feeds the fetus through the umbilical cord. And so whatever happens in the mother is ultimately reflected in the fetus. One single nutrient that can profoundly affect the fetus is folate. Folate, by its virtue of its role in DNA synthesis and replication, methylation of DNA, RNA, and proteins, gene expression and epigenetic regulation, as well as synthesis of neurotransmitters, can profoundly affect brain development and function. The story of folate and its connection to pregnancy-related complications goes way back to the 30s, even before the purification of folic acid, which happened in the 40s. And this was a young physician from Britain who went to practice in Mumbai, India at the Hafkin Institute. And what she noticed in her patient population was there was a large number of patients who were coming to her with anemia during pregnancy. And these patients also had many complications related to pregnancy. At the time when B-complex vitamins were just being discovered, Lucy Wills realized that Marmite, which is autolyzed yeast, is a rich source of B-complex vitamins, including folate, and she started treating her patients with this product. This product is still available in the UK and many other places, and children seem to have an avidity for this, for the taste of this product. A more definitive study was done in the 1960s at the Liverpool Royal Infirmary, and Brian Hibbard looked at a large number of women with pregnancy-related complications. And in summarizing his publication, he stated folate supplementation should be done from the very beginning of pregnancy and even before conception if complications of pregnancy and fetal abnormalities are to be avoided. This prophecy still holds good. So there followed many clinical trials in the 80s, and in the early 90s, it was decided that grain should be fortified in order to raise the folate status in the general population. And so US and many other countries used food fortification with folate, and this over the years reduced the prevalence of neurotube defects by about 30 to 50%. It did not completely eliminate neurotube defect pregnancy, but it did have a positive effect. Also, there was a contributing factor of regularly prescribing prenatal vitamins during this time. Folate is essential for methylation, DNA synthesis, cellular replication, and therefore plays an important role in reproduction, pregnancy, and embryonic development. In the mouse model, folate receptor alpha knockout produces neurotube defects, and folinic acid prevents this. Folate receptor alpha is the primary transport of folate into cells, also the primary transport of folate from the mother to the fetus. Folate supplementation significantly reduces neurotube defect pregnancy. However, women with neurotube defect pregnancy are not folate deficient, and no gene defects of folate pathways were identified in these women. So what could be the potential cause of fetal folate deficiency causing neurotube defects? So in 2004, we published this paper in the New England Journal of Medicine, reporting the presence of folate receptor autoantibodies in over 70% of the women who had a history of neurotube defect pregnancy. As you can see here, looking at the antibody titer measured by immunoprecipitation of the IgG that brought down labeled folate receptor, you can see there was high positive folate receptor antibodies, and we knew this was specific, but it could be blocked by using excess antigen. And so in women with the history of neurotube defect, there was a significant number of women who had this antibody and accounted for more than 70%. So it was evident that autoimmune disorder and antibodies to the folate receptor could potentially have deleterious effect just by modulating the immune system, as well as perhaps destroying the folate receptor, the primary transporter of folate. So we looked to see if the antibody had an effect on folate transport. As shown here, the upper two lines in the graph here looking at folate uptake in KB cells, which are epidermoid carcinoma cells that highly express the folate receptor alpha, there was significant uptake over time. If from a patient, we took serum from a patient with the folate receptor antibody, that virtually blocked folate uptake into these cells. And if we specifically removed the antibody from the serum, uptake was restored. So what this experiment indicated is that there is a specific antibody to the folate receptor alpha, and it blocks folate transport into cell and could be the likely cause of folate deficiency in the fetus, even though the mother is replete with folate. So in this situation, mother has plenty of folate, but it's not getting to the fetus. And inspired by Samuel Taylor Coleridge's poem here, the fetus would be crying for folate because it's surrounded by folate, but it's not getting any folate. We have subsequently looked at subfertility, difficulty in conceiving population, again, as you can see here, there is a significant association of positive folate receptor antibodies in the group that has issues with pregnancy compared to the normals. We have since also looked at preterm birth, and shown here is percentage positive for the antibody, either binding, blocking, or either antibody, and this is in the mother. As you can see from the black bar here, these are the mothers with the preterm births. These are the term births in gray. And there was a significant association of positive antibodies in mothers with preterm births. In addition to that, when we looked at the cord blood, which represents the fetal blood, again, there was a significant association of increased folate receptor antibodies in the newborn. Subsequently, we have looked at another condition known as cerebral folate deficiency syndrome, which Dr. Raymakers has spoken about. Again, in this population, there was a significant association of folate receptor antibodies in those with cerebral folate deficiency syndrome. These kids at birth appear normal, but over time they develop neurologic disease akin to low functioning autism. And one characteristic they have is low CSF folate. And we were wondering why that was. And eventually when we measured the presence of antibody, that provided an explanation why folate uptake to the brain would be blocked by an antibody to the folate receptor alpha. These kids respond very well to folinic acid treatment. Following that data, in collaboration with Richard Fry, we looked at folate receptor or antibodies in autism spectrum disorders. Again, here, as you can see, blocking, binding, or either antibody presence, there was a significant association of these antibodies in the patient population diagnosed with autism spectrum disorder. This amounted to over 60% of the kids were positive for the antibody, and folinic acid treatment was introduced, and there was a substantial response to folinic acid treatment. Recently, we looked at families with a child with autism in the autism spectrum disorder, and shown here is blocking, binding, or either antibody presence. You can see that in the affected child, in the mother and the father and unaffected sibling, there is a high prevalence of the antibody compared to controls, which shown here at the bottom, indicating that this autoimmune disorder runs in families and is associated with autism spectrum disorder. There may be many factors that influence the final outcome. It is not necessarily the presence of the antibody alone. So we have probands that are affected, we have siblings that are normal. But typically in this situation, if there are twins, most likely they will both be affected. The association of pregnancy-related complications and developmental disorders is best illustrated by a case report which we were able to follow for more than a year. Shown here is the history of a single mother who got pregnant at age 33. She was getting the normal prenatal vitamins, as well as during her various pregnancies, she was also getting treatment for infertility with various drugs. She had spontaneous miscarriage in the first trimester. The second pregnancy, again, resulted in a spontaneous miscarriage in the first trimester. During the third pregnancy, in addition to prenatal vitamins and fertility boosting drugs, she was introduced to 1 milligram of folic acid. At this stage, she had developed a dichorionic, diembryonic twins. Twin A was terminated at 12 weeks due to encephalocele. Twin B was terminated at 17 weeks, and autopsy revealed heart defects as well as cohort plexus cysts, among other abnormalities. At this stage, she was referred to us for folate receptor autoantibodies. She was highly positive for both blocking and binding antibodies, and it was decided at this stage to introduce her a normal care vitamin mix, as well as 4 milligrams of folic acid and 5 milligrams of prednisone. She was also put on a milk-free diet because we had found that milk intake stimulates antibody production. Now, during this period, she had already planned for in vitro fertilization, and she went ahead with the IVF. However, she spontaneously miscarried at 9 weeks. She was still positive for antibodies at this stage. She continued on a milk-free diet and various folate. Leucovorin was also introduced at this stage, and prednisone was also continued during this time. Finally, after about 250, 300 days, her serum turned negative for the folate receptor antibodies. Soon after that, she conceived her 5th pregnancy at age 37, and she was getting various treatments, including folinic acid and methylfolate at that time. She remained negative for folate receptor antibodies. She carried to term and had a healthy baby. Shown here is the folate receptor autoantibody profile after the loss of third pregnancy here. And as you can see, this is where we put her on milk-free diet, folate, and prednisone. And as we followed her over the course of time, both looking at binding as well as blocking antibody, we could see a decrease in titer. The 4th IVF pregnancy was lost soon after that, around day 250 or so. And it is around day 300 she became negative for both blocking and binding antibodies, and she conceived naturally here, 5th pregnancy, and carried to term and had a baby boy. This is an example of how the autoimmune disorder affects pregnancy and how we can correct this and have a healthy pregnancy. And if one looks at the prevalence of autism spectrum disorder in the general population, as you can see from this graph, the trajectory is upwards, and it continues so. The objective would be to try and turn this trajectory downwards, and whatever intervention one could do to achieve that would be amazing. It would be an amazing contribution to autism spectrum disorders, as well as other developmental disorders that occur in the embryo. So the objective would be, going forward, would be achieve prevention of autism and related developmental disabilities by treating folate receptor autoantibody positive parents. The aim of the study would be to identify parents with an autistic child who are positive for the folate receptor autoantibody and determine whether intervention in parents with folinic acid prior to and throughout pregnancy can reduce the risk of autism in the offspring. We anticipate significant association of parental folate receptor antibodies with autism in the offspring. Intervention with folinic acid during pregnancy will significantly reduce the risk of autism in the child. What we learned from this study could also benefit young children diagnosed with autism and help us better treat these children during the course of their life. I would like to acknowledge funding from the Brain Foundation.
Super. That was a really super talk, Ed. Is there any questions? Do you see any questions in the chat box, Ed?
I'm just looking at it. 1 minute. Yeah, I think there's one there. No, I don't see.
There are a couple of questions on your, if you have the app, it's there on your questions.
Okay.
I can ask them if you cannot reach.
Yeah, would you please?
Is the classic advice of taking folic and not folinic acid during pregnancy harmful to mothers who may have these antibodies?
Folic acid is used today as prenatal vitamin. If it's given orally, it's readily converted to methylfolate and absorbed. So depending on the dose, most of the oral folic acid is converted right during the absorption, which takes about an hour to hour and a half to get to the serum blood level, and it's now mostly methylfolate. So yes, folic acid can be used where there are no issues with conversion to methylfolate. However, where there are issues, it may be better to give methylfolate or folinic acid, which can readily go into the pathways that are used in folate metabolism.
Is the negative FRAT test for both blocking and binding antibodies enough to rule out cerebral folate deficiency, and what other tests are needed? The child is also homozygous for MTHFR variants.
Yeah, so in this case, yeah, autoantibodies to the folate receptor alpha are one cause of cerebral folate deficiency. There are a few cases described where there are genetic mutations in the folate receptor alpha that could also result in cerebral folate deficiency. So if the tests for the antibodies are negative, I think they should really look at the gene.
Apart from leucovorin, are there any other recommendations for CFD?
Methylfolate will also work. It's not that it won't work. So that's a cheaper alternative to the more expensive leucovorin. But as we have done in many clinical trials, we have used leucovorin to avoid the issue of methylfolate.
How do you explain the development of these antibodies in the women? Once a female is positive for antibodies, will she stay positive all her life, or do the levels fluctuate down to non-detectable levels?
Levels can fluctuate, sometimes to non-detectable levels. Now, in the very first study that we did, neural tube defect pregnancy, these were women with a history of neural tube defect pregnancy, and we tested them anywhere from 5 to 8 years after they had a neural tube defect pregnancy, and they were still positive. Many times we see titers go from high to low, and sometimes the low means it may be very low to detect, but it may be still there. Remember, the cells that produce the antibody don't leave the body, they're still there. There is variation in the cell population, or also removal of the antibody by the antigen-antibody complex formation. So you will see fluctuations. Similarly, when milk consumption is high, you may also see a triggering upward trend in the antibody levels in circulation. One point I'd like to make here is that the folate receptor alpha is a membrane-bound protein. the antibody that we measure in the serum is an excess antibody after saturating the antigenic sites on the membrane. So it is an indicator, but it doesn't tell you to what extent the membranes are saturated with this antibody.
Last one, why does treatment with folinic acid reduce folate receptor antibodies?
It does not reduce folate receptor antibodies. Folinic acid is given at doses whereby it goes in via the reduced folate carrier. Some of it is converted to methylfolate. That can go via the folate receptor alpha or the reduced folate carrier. Okay, so it does not reduce the antibody per se, which are constantly produced by the B cells that are activated to produce it. Okay, this is why it is important that women and men be treated prior to having a child. If they have the antibody, if they're rigorously treated, I believe that you can reduce the risk of autism. So if there are any of these attendees with deep pockets, please contact us. We would like to do these clinical trials.
One more. What is the impact of fortified foods and folate in supplements when already taking methylfolate or leucovorin?
You see, one thing good about this folate, whether it's methylfolate or leucovorin or folic acid, it's a water-soluble B vitamin. You readily excrete what is not taken up by tissues within the first 24 hours or so. You pretty much excreted most of what is in excess. So there is no major damage or harm in taking these because it's a water-soluble vitamin.